Hello, everyone. So, today we have an interesting case. So we have a 33-year-old female who presented to the ED with difficulty swallowing for 2 days. So she's a 33-year-old female with a past medical history of diabetes, hypertension, dermatomyositis, psychosis, OCD, and asthma, who presented to the ED with gradual onset of difficulty swallowing for 7 days prior to admission. And it got worse in the last 2 days of the 7 days. Now, her symptoms stayed relatively the same in the first 5 days. Then they worsened in the last 2 days, as we mentioned. She didn't recall eating anything that might have caused the dysphagia or the difficulty swallowing. Of note, she's been undergoing evaluation by ENT for hoarseness of voice. That's been going on with her. And she also complained of a heartburn 2 months prior to this admission after finishing a PPI course that was started empirically for odynophagia, secondary to esophageal candidiasis, that resolved with the course of fluconazole. That was on a previous admission. And she didn't complain of heartburn or odynophagia during this admission. So her past medical history, again, the diabetes, hypertension, dermatomyositis, psychosis, OCD, and asthma, free past surgical history. And her home meds, she's on prednisone, 40 q-day, IVIG, Celset, 250 BID. These are for her dermatomyositis, the amlodipine for her hypertension, sertraline for her OCD, and for her diabetes, she's on Dispro and Lantus, and albuterol for asthma. No known allergies to any food or medications. She's independent in ADLs. She drinks 1 to 2 glasses of wine per week. She doesn't smoke, and the family history is non-contributory. Regarding the review of systems, the positives. So she has a rash and a progressive scalp alopecia. She also has difficulty ambulating and generalized weakness and fatigue. No fever or chills, no weight loss, no headaches, no chest pain, no shortness of breath or cough, no joint pain, no urinary symptoms, no nausea or vomiting, no diarrhea or blood in stool, and no cold or heat intolerance. So the vital signs, when she presented, the blood pressure was 127/77. She was slightly tachycardic to 101, and afebrile, sitting well on room air. The physical exam was notable for an oral thrush, no cervical lymphadenopathy or neck masses, normal eye exam in terms of the pupils, clear bilateral air entry, no wheezes or crackles or stridor, normal S1, S2, normal abdominal exam. Regarding her extremities, she had a rash over her legs, buttock, back, upper chest with some ulceration. Neurologically, she was alert and oriented. Her upper extremity exam was 5 out of 5 in terms of motor function. Her lower extremities, she had 4 out of 5 in terms of motor function bilaterally with a normal sensation. And she had the heliotropic rash noted on her upper eyelids. She also had scalp alopecia and thick keratinized skin in the scalp. Now for the problem representation.
So Suhail, before we go to the problem representation, I want to give people, if you can actually go back to the HPI slide, and we can give some people some time to ask any questions that you may have for Suhail in regards to the history of this patient, or any other information that you might want to know.
Yeah, I have one. What's up, Suhail?
Hey.
So tell me about this dermatomyositis. Like, at what point was this diagnosed? What was the workup like, or do we know anything about the workup? Does she follow with like someone for this?
So her dermatomyositis was diagnosed in April of 2021, and she follows up with a dermatologist and rheumatologist in the outpatient setting prior to admission, and it was officially diagnosed with biopsy.
Okay, and then in relation to that, so do you know when she started all of her medications for that?
Yes, so she's been on these 3 medications since she was diagnosed, so probably mid-April.
Okay. And we trust that she's compliant.
Yes, yes.
Have her steroids been tapered at all recently? Has there been like any changes? Like, did they start a slow taper or anything, or it's all been the same?
It's been the same. So she started with a higher dose prior to the 40 Q day, but because of side effects mainly in her glucose, it's been tapered down to 40 Q day.
Okay. And when she first presented with her dermatomyositis, did she have any esophageal involvement? Like, did she have dysphagia or any difficulty initially when she presented?
So in this current admission, this dysphagia is relatively new, provided that it's been going on for a week, but she had a history of adenophagia on a prior admission 2 months ago, and the diagnosis was made as esophageal candidiasis.
Okay, thank you.
In the chat, Fatma is asking any history of STDs in the past, and Finn is asking how long has she had this thrush for?
How long has she had the what?
Thrush.
Okay, so no history of STDs, and the rash, I would say more than a month.
Yeah, just to clarify, it was the thrush, not the rash, not the skin.
Oh, the thrush.
Yeah.
So the thrush, I'm not quite sure because it was caught on the physical exam, and the patient might not have noticed the rash on this current presentation.
Hi, Suhail. I actually had a question on the rash. Is it? I know you said it's been there for a month now, but has it been the same? Has it been increasing, decreasing?
Prior to this admission, when I read the outpatient notes, it seems that the rash has been progressing. And that was the reason for, so during her current admission, the last one, rheumatology were on board because of that.
Okay, thank you.
Suhail, can you tell us more about this like dysphagia location, and is it like for solids, fluids, or both? And is it associated with adenophagia?
All right. So as we said, she had a history of adenophagia 2 months prior to this admission, but during this one, she didn't have any pain while swallowing. And she feels that the dysphagia is in the upper part of her esophagus, mainly the upper part of the chest and the neck area. And it started with solids and liquids at the same time when it started a week ago.
Is it associated with like shocking sensation when she eats, or coughing when she eats, or any like other symptoms of like other swallowing like difficulties? Or
so yeah, we expected that she might have these symptoms given that she located the dysphagia in the upper part, but she denied any choking or coughing.
And now no heartburn, no regurgitation, nothing like that, right?
No, no.
We also have a few questions on the chat. I don't know if you can see them, Suhail, but Matthew Alexander is asking if she was diagnosed with an EGD for esophageal candidiasis, and if there was any malignant workup after the diagnosis of dermatomyositis. And Arohi is asking if through ENT, there have been, like, if she has followed, since she's following with ENT for the hoarseness, has there been any like scopes or anything done so far to evaluate?
Okay, so regarding the adenophagia that she had previously, it was empirically treated with fluconazole, and the adenophagia resolved after that. So the diagnosis was made in retrospect that she responded to fluconazole. And regarding the ENT, so when they did actually a laryngoscope, and they attributed the hoarseness of the voice to thickened vocal folds. Regarding the malignant workup, it hasn't been complete as she's still following with rheumatology and dermatology in the outpatient setting. But it's negative so far, what has been done.
I think we can move on for the sake of time. Well, Wakar just had one last question. If she last received any, when she last received any IVIG, and if there's any muscle tenderness.
Okay, so the last IVIG, she used to have the IVIG twice a week, and she hasn't had one in the past, I would say 3 weeks prior to admission, but she had IVIG during the admission. And what was the other question?
No, that was the last one, and I think we need to move on just to problem representation, just in the sake of time.
Let me just ask one more thing. The diabetes
okay.
is something new, or was it triggered by the prednisone? And the
She
second
had a
question,
history.
yeah,
Yes.
go ahead.
She had history of diabetes originally, but her readings started to get worse after she was started on prednisone.
Okay, and then on the physical exam, you mentioned a rash with some ulceration. Can you expand on that?
So it's kind of scratches versus ulcerations from the repetitive scratching.
Okay, thank you.
Mhm.
Okay. So for our problem representation, does anyone want to take a stab at it and try to just summarize this case with what we've been discussing so far? Shavari, you want to go ahead and give it a shot?
So this is a 33-year-old woman with past medical history of type 2 diabetes, dermatomyositis, presenting with subacute onset of odynophagia. Also significant for recent diagnosis of esophageal candidiasis. With I forget, can we go back to the exam and the physical?
Yeah.
Sorry, I think I remember now. So the vitals, unremarkable vitals with mild tachycardia, physical exam significant for oral thrush and a diffuse rash and some heliotropic rash around the eyes. Yeah, I guess that's it. That would be the problem.
Okay. You want to go ahead and show us what you summarized, Suhail, so we can compare? Okay. Yeah, go ahead, Suhail.
So yeah, a 33-year-old female with a past medical history of diabetes, hypertension, dermatomyositis, psychosis, OCD, asthma, presenting with 7 days of difficulty swallowing that got acutely worse in the last 2 days. And now for the workup.
So yes, for workup, I mean, would anyone like, what kind of workup would you order for a patient like this? Would you normally go ahead and like, what kind of labs would you start ordering for this patient, and would you order any? And why? So Abhinav, would you order, like, what kind of workup would you order for this patient? Like, would you get any labs, like I said, imaging or anything in particular that makes you think in this case?
I think first of all, I don't know if I had but very quickly, is this patient admitted because she can't tolerate any PO, or can this be worked up outpatient? I think first that was my thought, and if not, then I would get basic labs. If she's not eating at all, I would get like at least CBC, BMP, and LFTs, and a FOS, just to begin with.
Okay. Yeah,
In fact,
I agree. I mean,
I'm not really looking for anything particular. But if she doesn't look infected, if her vitals are stable, she doesn't have fevers, she doesn't look like she has an acute bacterial infection, and she's tolerating PO, I don't know why she's admitted.
yes, I think those are great points, Abhinav. Probably like just the past medical history of dermatomyositis and the fact that it's worsening, and like this patient already had, you saw how many medications for dermatomyositis. I'm sure that probably influenced the decision when admitting. But I would say, yes, it's a great point. You have to know like how bad is the dysphagia, has like not just how bad, but like how chronic is the patient also, like, you know, having hematemesis or just vomiting, or like, is this chronic? Is there any weight loss? Like all of those are things that can point you one way or another. Speaking of medications, of course, like the immunosuppression, like you can think infection if, and we'll talk about it a little bit more later on, but you know, if this patient, let's say, is coughing, and you might be worried, like if you are worried that the patient might not be protecting their airway, and you might think about pneumonia or infection, other stuff like that, that would be valid. But yeah, like a patient just coming with dysphagia, you don't necessarily have to go and chase everything. It's very, you have to be a little bit nitpicky about the history. Eric is saying here he would add ESR and CRP, LDH and CK, suspecting a flare of dermatomyositis, which I think is valid.
Yeah, I've been able to answer your question too. I would think that, you know, this is a very immunosuppressed woman. The fact that she's young, you know, don't make us think that she would mount a fever. She might, you know, we know the tachycardic arrest. And, you know, of course, there are lots of reasons for that. She just could be dehydrated from her dysphagia and maybe not drinking enough. Right. But considering that she's severely immunosuppressed with medications, with diabetes that we don't know if it's well controlled or not, you know, to me, the tachycardia makes me uneasy to send her home. Sometimes you can find an answer right there, you know, to see why she's tachycardic. Maybe you examine her again and she's not tachycardic anymore. But in the meantime, that to me is a red flag.
Definitely.
Great point. Thanks, Dr. Pergolini. And Nora is mentioning HIV, chest X-ray, EGD. I mean, that would be a little bit more advanced workup, but yeah. Okay, so you can go ahead and talk about the results we have.
Okay, so here are her labs. Basically, the chemistry was unremarkable apart from a slight elevation in the ESR and CRP, normal liver function enzymes, and the CBC was grossly unremarkable with a normal BBG. And this is the EKG, and which is sinus rhythm. This is the chest X-ray, no consolidations or infiltrations, basically a clear chest X-ray. And now for the differential diagnosis.
So I think, Suhail, I'm gonna stop you there for a little bit, just for a brief discussion. Let me see.
Mm-hmm.
Okay, everyone. So we're gonna have just a brief discussion about this case, and I guess just dysphagia in general. So I'd say dysphagia, it's once you start the workup, I guess, for the first part, is very important to ask open-ended questions. And that's why I stopped a little bit in terms of the HPI to see if you had any questions, because really for the workup of dysphagia, you can get a lot from the history, and yeah, you basically have to take into account, like have a very good questioning and really look at the patient in front of you, like Dr. Pergolini was saying, you know, take into account the history. In our case, our patient has several important points, such as the immunosuppression and the fact that she's young, tachycardic, all agreed. I would say for like in general, the structure of how I like to think about dysphagia is like just starting with I guess the phases of swallowing initially, just looking at it like, you know, so just the passage of food from the mouth into the stomach. So it's, you have an oral phase when swallowing, and really that is just, you know, the mastication and the salivation. So I mean, just taking into account of your patient, for example, this patient has a history of dermatomyositis, if there could be superimposed like Sjogren's, like you can start thinking about stuff like that. And just in general, like if you have an elderly patient with poor dentition, that's definitely something that matters, and it's why our diet and SLP evaluations matter a lot in patient as well, like the textures, depending on the type of dysphagia the patient has. Then you have the transition or pharyngeal phase, which is basically a lot more complex, and it's partially voluntary. Like it starts with the tongue, like the hypoglossal nerve, but also the like I was mentioning, the elevation of the larynx to protect the trachea, and that is another phase. Really, like between those two is mostly what we talk about, the oropharyngeal phase, and after that, I mean, it's just pretty much the esophageal phase, which takes into account just the transition from the pharynx into the esophagus, and just the normal peristalsis. It's we're gonna talk a little bit more about that, but just in general, once you're talking about dysphagia and your diagnostic framework, what is the first step? Like, what do you have to divide based on the history, or what do you need to make in terms of what type of dysphagia it is? And I kind of mentioned it before, just talking about the phases of swallowing, but it's really important.
Oropharyngeal and esophageal. Perfect.
So just give me 1 second. So oropharyngeal and esophageal. So, and like I said, this is pretty important in terms of the history. So starting with esophageal, what kind of questions or what kind of presentation and like would you expect in someone with esophageal dysphagia? Or let's say, so dysphagia is partially, like the feeling or sensation of food getting stuck. What would point you more towards thinking of esophageal dysphagia as opposed to oropharyngeal?
Sometimes the location can help.
Yes.
Like beside location, like what type of, like, is it for fluids versus solid, or is it for both? The acuity, like, or the progression of it, the association of any problem with swallowing, if there is any cough, talking, or aspiration, like would go with pharyngeal.
Okay. So yeah, in terms, very good. You mentioned a point for oropharyngeal, and I would guess, like you mentioned location a little bit. So yeah, esophageal, like you said, it's mostly in the chest or below the suprasternal notch, and also like just the feeling of food getting stuck in the chest. But keep in mind that these feelings of sensation and dysphagia are also dependent on the patient's sensory system, and like the patient actually being able to detect this. So meaning if you have like, I don't know, an elderly patient with many decades of uncontrolled diabetes, you might not get the same sensation as let's say this younger patient who hasn't had diabetes for as long of a time. But you really need an sensory system to actually describe these symptoms. And so I would also say in this case, pain, like it's not necessarily I'm talking about like esophageal and oropharyngeal, but if this patient described pain as well, like what would that trigger in our minds, especially in this patient with their history?
Infectious.
So yeah, and what kind of infections would you expect in this patient who has steroids, IVIG, and Salseps as well? Basically pretty immunosuppressed. What are the typical ones?
Candida, herpes or CMV less likely. I mean, but she
Yeah.
can have
Yeah, I agree. So basically what I'm talking about is just like trigger a workup for esophagitis. And then, so that's great. And then I'm gonna just briefly talk about, so oropharyngeal. So you mentioned something, Nora, right? About oropharyngeal. What kind of symptoms would you start expecting with that, or anyone really?
You could have like secretions, like oral secretions.
Yes, perfect. So yes, you can have secretions. Basically, I think Nora had mentioned like nasal regurgitation, and with secretions, like you said, basically I would specify maybe a little bit like drooling or food outside of the mouth. What other symptoms or associated symptoms would make you think of something more oropharyngeal as opposed to esophageal?
Cough.
Excellent. So cough as well after initiation of the swallow. And so we talked about a little bit about location for esophageal, right? So if esophageal is mostly a sensation on the chest, really when you're talking about oropharyngeal, you're talking about more above the suprasternal notch. And these are just general guidelines of you to, start thinking about the how to divide dysphagia and kind of start tackling any case that presents to you with dysphagia. And then I think, so Nora, you started talking as well, and I kind of cut you off, but so basically for esophageal dysphagia, which is what we were talking about, it can also be subdivided into two different types of esophageal dysphagia, and this is where it is important to ask as well about what you have dysphagia with. So we talked a little bit about solid food versus liquid food. Sometimes you have it for both, sometimes you don't. So why is that important in terms of the workup of esophageal dysphagia?
When you have
Mechanical versus a functional obstruction.
Okay, perfect. So yes, pretty much. Thank you, Avinav. So basically, sorry. Basically, you can have motility. Sorry. And here you can have structural. Perfect. And then I guess, so what are some examples of just what would you think about when it comes to structural in this patient, I guess, given this case, or just in general? What are some differential diagnoses?
malignant mass.
Malignant mass, great. Especially, I mean, I know you were talking about the diagnosis of dermatomyositis, and if the patient had, a prior workup for malignancy. So really, you would think that once you divide, into structural, you can think of as well like intrinsic versus extrinsic. So when you're talking about a malignant mass, like you can talk about like in this patient who was mentioning, like gastric reflux. Like if the patient has a significant history, you can think about, potentially even like adenocarcinoma, but you can also have just a peptic stricture as well that can be, slowly progressive. So you have to start thinking about like other symptoms such as weight loss, and like I said, in this case, dermatomyositis as well. So I mentioned the malignancy, like it can also be extrinsic, such as like a mediastinal mass, for example. A thymoma can also cause dysphagia. And in terms of, I guess now that we were talking about extrinsic structural compression, what else could you think of? And I mean, we did get an EKG, but I wouldn't recommend getting it for everyone that just comes in with dysphagia.
Just for the acuity of this, like this patient symptoms, I would go with something maybe she might have malignancy, but like given the acuity, I would go thinking about something acute like infectious, even if she doesn't have odynophagia. Sometimes patient would express their pain with just like, I have dysphagia or something. So they would, I'm not sure. So she might have something infectious, esophagitis. She might have, due to the dermatomyositis, something like oropharyngeal, because it can affect the straight muscle in the upper third of the esophagus. Also, diabetes can cause motility dysfunction of the esophagus, but that would be like chronic issue. So
yes. Yes, and right now I'm talking also just like differentials in general, not necessarily for the patient, but you're completely right. Another thing that you can think of when you have like an acute obstruction is also just food impaction as well is fairly common. But yeah, basically, so you have structural, and once you can think of extrinsic and intrinsic, but you also have to think, you know, episodic versus progressive. Like you were saying, malignant mass generally progresses throughout a longer period of time. And let's say something like, you know, Schatzki's rings might be a little bit like food dependent and might not be as persistent. And now for the sake of time, we can just move into motility disorders. So with motility disorders, you also think of you know, episodic versus progressive. So what kind of motility disorders would you think of that are progressive? And just in general, I guess, if you had like your regurgitation and weight loss, you could think about achalasia. Whereas when it is a lot more episodic, you can just it can just be secondary to an esophageal motility disorder. So just like spasms, and so moving on to oropharyngeal, like I said, you can also do it based on the same division, just motility. Sorry. Motility and structural. So some examples, I guess, of motility disorder, disorders in the oropharyngeal level. And like we were mentioning, you know, the upper esophagus is striated muscle, and it is a little bit more. Sorry, what were you saying?
Like a spasm of the vocal cord.
Oh, okay, spasm of the vocal cord, like, or what? Sorry, weakness. Okay, so like yeah, that
like with the adduction or the movement.
Okay, so muscular weakness, and in our patient, I mean, that would kind of make sense as well, right? Like with a history of dermatomyositis. So very good. But also since the initial phase of swallowing it's mostly centrally mediating, this is the type of dysphagia that you will also see a lot in patients with, for example, stroke. And you can see it in other disorders such as, you know, Parkinson's and yeah, in general, you know, central disorders. And yeah, because motility, basically, like Shavari was mentioning, you can also divide into pretty much neural or muscular. So there's a big differential there. And in this part, just like some of the typical structural disorders, like if this patient had halitosis, let's say, or regurgitated food, what would that make you think of?
Diverticular.
Yeah, Sankers. And another possibility is just like cervical osteophytes. And also, I mean, malignancy can be both in the like below or above the neck as well. So you can have really, you can have that as a differential, like pretty much for both oropharyngeal and esophageal. I would say, just to add quickly, like in regards to, like I said, always taking into account the past medical history. So some of the things that are like, I guess, in our patient history and are kind of associated with a specific diagnosis, like I would take into account, you know, this patient has asthma that is sometimes related with eosinophilic esophagitis. This patient has a psych history. So, I mean, you can also clarify like whether that has, the patient has global sensation. This patient has like is immunosuppressed. So we talked a little bit about the differentials, like Noor was saying, despite the fact that she's necessarily not describing pain, like I mentioned, really in the workup and differential dysphagia, it's very important to just make sure we're asking the right questions the right way and actually listening to what the patient is saying, and keeping into account that it's something that could be a little bit difficult to describe. And like Dr. Pergolini was asking, you know, diabetes, that can definitely have an impact in the propulsion of the food bolus and also in the sensation as well. I don't know if anyone has any questions about this or anything to add. Oh, and another one I forgot to mention was, I guess, history of gastric reflux. So in patients with prolonged gastric reflux, you can also get esophageal strictures as well. That can be progressive. And we also have, so we have DM for diabetes, but we also have dermatomyositis, right? So like Shavari was mentioning, you know, you have to keep that into account as well, the muscular component of the swallowing phase. And in this case, I mean, not just that dermatomyositis could be a cause of the difficulty swallowing, but if this patient already has this disease, like could this patient potentially have another rheumatological disease overlapping as well, like we mentioned, you know, Sjogren's, like with preparing the gastric bolus, or even, you know, something else like scleroderma or something else. Not sure, but just something to keep in mind, I guess, once you start having all these words in your history, it kind of broadens your differential a little bit.
And I just wanted to add, in terms of structural, I know in our patient's case, they had an ENT exam, but anything like an infectious, like epiglottitis or tonsillar abscess, could be structural in the oropharyngeal area. And also Lemire syndrome, which is sort of like a IJ thrombosis, can also cause sort of dysphagia. Some of the infectious causes obviously not relevant in this case.
Great, thanks, Shabari. If anyone else has anything to add, and if not, Suhail, you can just tell us how this case unraveled.
Right. Let me share my screen. So yeah, back to the differential, oropharyngeal dysmotility secondary to dermatomyositis. Since he had the thrush and the past history of esophageal candidiasis, so we have to think about that as well. Global sensation, given the history of her OCD and psychosis, and other less likely diagnoses like achalasia, or other associated connective tissue diseases like scleroderma, given that she also has dermatomyositis, so she could have other connective tissue diseases, and esophageal strictures because of acid reflux. So she did the EGD, which was basically unrevealing. There was a small hiatal hernia, but otherwise everything else was normal. Biopsies were done to the upper and lower esophagus, and the pathology was benign. Barium swallow was also done, which was also normal. No structural abnormalities were caught on barium swallow. Now, this is the part where we kind of like started to know the cause of her dysphagia. She did video fluoroscopy as an outpatient after she was discharged. And one thing that I forgot to mention is that when the EGD was done as inpatient, they did something called empiric dilation because no apparent reason was found. And after the EGD was done, she kind of reported a temporary relief after the dilation. So the video fluoroscopy showed something called pharyngeal pooling and nasal regurgitation of the barium that she swallowed during that exam. And video fluoroscopy is basically the same as a regular barium swallow, but it focuses on the cervical part of the esophagus. And the video is of higher quality. More images or more X-ray images are caught during that exam. So the video that is played is smoother than the barium swallow. And this is what she had, dysphagia secondary to dermatomyositis. Now, the dysphagia and dermatomyositis, as Noor has mentioned, basically affects the skeletal muscles of the oropharynx and larynx, which are basically in the upper part. And this is what Rafa has discussed in details. Do you want me to go over it again, Rafael? So it's basically...
It's just, if you have anything additional to like what I said, or any like particular highlights for you, or how you approach the dysphagia.
So the highlights basically, the first thing to focus on, if this is esophageal or pharyngeal, 3 key things to ask in the history to kind of gravitate towards oropharyngeal, and that is if the patient has coughing, choking, and nasal regurgitation, which is very specific for oropharyngeal, and if they report difficulty in initiation of swallowing. And if none of these are present, and if the patient reports that they have difficulty or they feel the food is getting stuck after they swallow, then we think about esophageal. And if we think about esophageal, then the next thing to think about is it to solids or solids and liquids, or only liquids? If it's for solids, it's basically mechanical. If it's liquids plus minus solids, then it's more of a motor disorder. And the next thing to ask is if this is progressive or intermittent. And as Rafael has mentioned, each one has its own differential to think about. Now, if it is oropharyngeal dysphagia, we go for video fluoroscopy. And these are, I mentioned before, the differences between video fluoroscopy and the regular barium. The limitations for video fluoroscopy, it's limited, as we said, to the upper part of the esophagus, and it resembles ultrasound in that it is operator dependent. And there hasn't been a clear criteria to agree on the normal and abnormal findings when the video is shot. So it's kind of unclear, or there hasn't been a clear consensus on the abnormal and normal findings on the video. These are the drawbacks of video fluoroscopy. Now, this is, I brought this from the internet, but this is to show a patient with dermatomyositis undergoing video fluoroscopy. So this is what is meant by pharyngeal pooling. As you see, as they swallow the barium swallow, you can see it should be a smooth straight line going from the mouth to the esophagus, and the pooling is right over here where the it's kind of like collecting. So that's what is meant by pharyngeal pooling of the barium. And this video is for a patient with dermatomyositis prior to starting therapy, which is basically steroids. And the next half of the video is for the same patient, but after the dermatomyositis is controlled by steroids. So this is the nasal regurgitation, and you can see as the patient is swallowing the barium, it shoots up into the nasal cavity. So that's the nasal regurgitation. And the second half of the video is for the same patient, but after the steroids are started and the disease is kind of controlled, you can see the nasal regurgitation is no longer there. A few things to note about esophageal dysphagia. Sometimes we do barium swallow prior to EGD in basically two scenarios. If we think that the stricture is tortuous, meaning that there are strictures in more than one site and the esophagus is kind of bent and collapsed on itself. If we do endoscopy prior to barium swallow, we might actually perforate the esophagus going into a wall. So post-caustic injury or radiation suggests a tortuous kind of a stricture. And if the history is suggestive of a proximal esophageal lesion, because sometimes if we do endoscopy and the pathology is in the upper part, it can be missed on endoscopy and it can be caught on barium swallow. Sometimes we do post-endoscopy barium after EGD is done, and that is if the EGD is negative in esophageal dysphagia, and we still think a mechanical obstruction is the culprit, basically for extrinsic compressions, which can be missed on EGD because the EGD focuses on the lumen, or an esophageal ring, which can also be missed. Manometry, we usually resort to that if, again, the EGD is unrevealing, but this time we think the disorder is a motility disorder like achalasia, for example. But in these things, we haven't actually done manometry or post-endoscopy for our patient because she has oropharyngeal dysphagia. And the patient course, so her dysphagia improved after the empiric dilation, and her medications were up-titrated to from oral prednisone to IV solmidorol, BID, and she was started on hydroxychloroquine. And she noted a relief from her dysphagia after these medications were increased, and she was given IVIG while she was inpatient. Take-home points. So when we ask the history about the dysphagia, there is actually, regarding the patient's perception of the site of the dysphagia, where the patient feels the dysphagia, might not usually correlate with the actual site of the pathology. Though like a more proximal dysphagia in the upper part of the chest is felt, the more it correlates with the actual site. Like, for example, if the patient feels that the dysphagia in the lower part, the pathology might be in the upper part, because most of the sensation of the esophagus is referred proximally. So upper sensation of dysphagia usually correlates to the actual site of the pathology, but that's not the case if it's felt lower in the chest. And again, dysphagia to solids, we think about mechanical disorders. Dysphagia to both solids and liquids starting at the same time, motility disorder. If it starts with solids and then progresses to liquids, then of course mechanical disorder. And oropharyngeal dysphagia, three things to focus on in taking history: difficulty in the initiation of swallowing, choking and coughing, and nasal regurgitation. And that's basically it. All of this.
Thank you so much, Suhail. So I also want to apologize to everyone because I wasn't getting the chat notifications. So I'm sorry if I just saw that I missed some comments. But thank you so much for participating. And it seems like we also have a few minutes for questions. If anyone has any questions regarding this case or just how everything unfolded.
I have a question. Thanks, Suhail. That was a great case. So I'm just very curious about the dilation in this case, because usually esophageal dilation is done in patients with like a stricture or malignancy. And even in those cases, it's usually not very effective because it usually recurs. Depending on the etiology of the stricture or the etiology of the obstruction, dilation is a very controversial procedure. I'm just curious in this case, what would you dilate? Because you don't really have a mechanical obstruction. And in this case, it seems like it's more oropharyngeal rather than esophageal. So any insights on what was the rationale behind a dilation, and like what would you dilate specifically? Because you can't just dilate the entire esophagus. It has to be like a 5 centimeter segment.
All right. So I was on GI consults when the endoscopy was done. I was with the attending, and when he first saw the patient, he kind of thought it's mostly secondary to dermatomyositis. But since her history was kind of atypical, given that she didn't have the classic nasal regurgitation or choking on food, when the endoscopy was done and everything was negative, he kind of like, since like we are already in the esophagus, he's going to empirically dilate. Probably that will help her temporarily until we figure out what's causing the dysphagia. So there wasn't really a clear cause of why dilation was done, because anatomically nothing was found, like no achalasia or anything like that. But she kind of felt better after it. I mean, I agree, it wasn't really a typical course. And the video fluoroscopy was done after she was discharged in the outpatient setting, which we already planned for that to be done after she was discharged.
So it was empiric dilation of the distal esophagus?
Yes, actually, to multiple parts of the esophagus, like distension of a balloon for like 60 seconds in like 3 parts of the esophagus. Yes.
Okay. No, just in general, dilation is a very, very controversial procedure, because obviously it causes a lot of it's an intervention causes some higher rates of pneumo, like perforation, and so it doesn't really have the greatest data behind it. So I'm just curious about why it was done in this, where it was not even, you didn't have a focal lesion.
Mm-hmm.
Thank you, Suhail. We also have a question for Fatma. Just how was it confirmed that it was functional dysphagia in the setting of dermatomyositis? And just talking about that the biopsy was normal, nor saying that she thinks that the biopsy was just mucosal, they wouldn't see muscular. But just curious, I guess, how they confirmed that it was secondary to the dermatomyositis. And
yeah, so as Noor mentioned, the biopsy was basically mucosal to rule out any malignant cause. And the video fluoroscopy kind of confirmed that it's mostly dermatomyositis, given the pharyngeal pooling and the nasal regurgitation. And she kind of felt better after her prednisone dose was increased and the hydroxychloroquine was added. But no muscular biopsy was done to the esophagus during that endoscopy.
During this admission, was the CPK increased?
Like, weirdly enough, it was kind of unremarkable, the CPK. So yeah, probably it was high because she waited like 7 days for her dysphagia until she presented. So probably it was unreportedly increased, like undetected. I'm not sure about that.
And we mentioned no significant like she had increased weakness, and muscular pain.
Yes, in the lower extremities bilaterally, which is not new to her. Like, she has difficulty ambulating, basically because of the proximal lower extremity weakness.
And someone is asking,
but a manometry, after the first episode, because to me it sounds like there must have been some manometry measurements, to decide on dilation. Because otherwise, I agree with Anga that it would be unusual.
Yeah. So yeah, it was actually like debatable whether the attending wanted to do dilation or not while the endoscopy was done. That's why, like, when I read the note, it said empiric. Manometry wasn't done because he didn't suspect the like a lower esophageal motility disorder. Most of the thinking was that the motility is in the upper part of the esophagus.
Okay.
Or the oropharynx.
Thank you.
Mm-hmm.
And someone asked, what about the rash with the ulcers?
What about the rash? So yeah, the rash. Like, during that admission, rheumatology and dermatology were consulted to kind of control the rash, which, according to the patient, has increased in the past couple of days prior to admission with the scalp alopecia. So that was because of dermatomyositis. It was mostly like scratches versus ulcerations, but basically physical trauma because she was persistently scratching.
Last question, did the patient have a malignancy, or was it the patient worked up for a malignancy?
The workup, so according to the outpatient notes prior to the admission and like the images, they were all negative. But regarding the like completion of the whole malignancy workup, I don't think it was complete. Like they still have to do a couple of tests in the outpatient setting.
Okay, and I guess probably the last question that we're going to take, just in the sake of everyone's time, but Kirtana is asking, is skin flare associated with muscle manifestation worsening in dermatomyositis? Yeah, for that, I'm not sure, to be honest. I mean, you do have some types of dermatomyositis that are purely skin related, and I assume it's mostly because of the skin manifestation that they added the plaquenil, as opposed to actually thinking of like the muscular manifestation. But I'm not sure if necessarily the skin flare is associated with like if they always have to be correlated or not, like skin and muscle.
I remember this patient. I was in room consults when she was admitted, so I followed her throughout the whole course. When she came in, the dose of steroids she was on was significantly lower because she was having difficulty tolerating the steroids. And the other issue was she was kind of due for the IVIG, recently started on CellCept, but not doing well. And she was very weak and very short of breath. So another one of the main concerns was that she had diaphragmatic involvement. But I think the rash itself was getting much better compared to at least the onset of the dermatomyositis. And it was very typical, like in shawl distribution, the V sign, the heliotrope rash and the Gottron's papules were pretty typical of dermatomyositis. And the dysphagia also improved. The steroids went up from prednisone 40 to salumedrol 60Q12 initially. So she did improve a lot with a significantly higher dose of steroids after the infection workup was mostly negative. I think that also weighed in on, it was dermatomyositis more than other etiology. And the malignancy workup was, she had a colonoscopy, the EGD was pending, which was the weird part because she had the dysphagia. And she had only the mammogram pending, but then PET scan was negative. So it was just mammogram, and I think that's the only thing she had pending, but otherwise everything had been negative.
Okay. Thank you so much. We're basically cheating with all the consulting services here. But thank you so much for your input, Ricardo. That's great. And thank you so much for the great presentation, Suhail. I think I'm gonna let everyone go because it's 5:06 and I know people wanna just get some rest, well deserved. Thank you everyone, and I hope you have a great rest of your day.